I was called by WHO in beginning of August to help coordinate international efforts to come to the West African countries. And I first was based in Geneva to coordinate and try to get international teams mobilized to go to the area. And later I was also deployed to Sierra Leone to coordinate these teams. However, in the beginning there was very little to coordinate because there was nobody there except for MSF. So there was a lot of interesting stuff to learn from this that will, I think, also affect how international teams or foreign medical teams will respond to upcoming disasters. There is now, for example, I was at a meeting at WHO quite recently where we discussed the experience from this outbreak. And China, for example, have 17 foreign medical teams ready to deploy very quickly. So I think increasingly we will see this type of response to disasters, mainly probably sudden onset disasters such as the typhoon that we saw in Vanuatu last week, but probably also to large scale sudden onset such as earthquakes. And there will be many teams coming, and they will be very crowded on the spot with this team. And it could be that responding to this type of disaster will become a new foreign policy tool. It seems like there's a lot of interest from politicians also to equip their own foreign medical teams, to send it and to show that this country is really acting in the name of solidarity, while actually there could be other purposes behind doing so. So I think one of the most important things when you plan to respond to a disaster outside your own home country is to understand the context. And I think that's one of the main challenges when medical teams from high-income countries are deployed to low-income countries, because we are not aware of the situation there. We are not aware of what the situation looks like on a day-to-day basis. We are not aware of the health systems, their strength and their weaknesses, the cultural issues. And this is a main challenge and something that I've been working quite a lot with at Karolinska in trying to train people going to go to work, not only in this Ebola outbreak. We did a number of courses for Swedish teams being deployed, but also in general in global health. And I think among you do a lot of that type of teaching as well, and I think it's very important. But roughly and quickly going through the specificity of the context in this in the three affected countries, basically 22 million people, and all three of them are low-income countries. And what is striking is, for example, that literacy rate among the adult population is less than half. Less than half the adult population can read and write, and that's something you have to take into consideration, obviously. And also that Sierra Leone and Liberia, they are recovering from years of conflict. I worked in Sierra Leone in the end of the 1990s, following this horrible massacres, and you might have seen the movie Blood Diamond, and the situation was really bad, and the country was slowly sort of recovering from that, and then there's a setback with this outbreak. Obviously a lot of problems with governance and trust of the public, that politicians and decision makers don't have, people don't listen to them. The social contract that we have between our decision makers and the public is not there simply. There's no system to collect tax, etc. And then if you look specifically on the health systems, which I think is sort of our counterpart if we're going to deploy teams to the area, it's clear that for example, if we focus now on Sierra Leone, because I think that's more relevant for the Norwegian context, as you have teams deployed to Sierra Leone. In general, there's not much more than 200 doctors, and the under 5 mortality rate is close to 20%. And if you look on all the different sort of indicators, there's a factor 100 difference compared to Norway. So, for example, you have 100 times more doctors per capita in Norway compared to Sierra Leone. And the same thing with under 5 or health expenditure per capita. So, and then you see the out-of-pocket share it's close to 90 or over 90%. So it's a totally different context compared to our high-income setting. And this is I used to have Hans Rosling as my PhD supervisor, so I need to show this graph every time. But you all know it. Here we have life expectancy. Here is income per person, and the 3 affected countries are really down in the lower end here, with Liberia even off the map because the income per person per capita is so low. If I had been born in Sierra Leone, I would not be standing here because I'd be dead. You know, it's life expectancy is under 50 years. So it's really countries that already before this crisis, and maybe you can say as a reason for this crisis arising, is that they were already before not very well off. And this was the situation when I was called by WHO, that actually people were dying on the street. There were dead bodies on the street. There were not enough isolation beds, and that was the main reason for calling for international assistance at the time, the lack of treatment or isolation beds. And then if you look on Ebola in general, we know pretty much of what needs to be done. We know what are the 5 pillars. If these 5 pillars are being done, depending on priority, you can stop the Ebola outbreak. That's clear. And there's been around 25 outbreaks previously since 1976. And if you do these 5 pillars, or if you implement them in a way, then the epidemic will stop. And it's clear that in the beginning, this case management and isolation was really the top priority. There was a desperate need for Ebola treatment. It was called Ebola treatment units at the time. Later they call it Ebola management units because the treatment side of it was really toned down because actually there was not much treatment being provided at these centers. It was more isolating the patient and really a utilitaristic perspective of getting the infected person from the community in order not to infect more. And that person, that once they were admitted to these isolation units, there was still a very high case fatality rate, around 60% as of yet, when all the data has been compiled. So actually the added value of somebody being lifted out of their community to be isolated was not very much. And while people who have been evacuated from the affected countries have around a 20% case fatality rate. So for those being evacuated, of course, it was better to be evacuated. But for people that caught Ebola, it was more to save the community or to save their family that they were isolated. In general, you could say August, September that it was difficult to mobilize resources. Obviously, the national resources were limited. It also took quite some time to understand that this actually was an outbreak. It took over 3 months until it was defined as an Ebola outbreak. And what we saw also initially was a lot of staff being infected and dying from Ebola, which really also brought down the national capacity to respond. And staff salaries was an issue, obviously with an underfunded health system that remains an issue. There was lack of protective equipment. Then, of course, who is going to be leading, the response? 3 countries being affected, and initially WHO would not really assume that leadership. So WHO has been under hard criticism, and I think there will be a lot of evaluations further down the line that will highlight what WHO did and didn't do. The problem was that it was over-relying on MSF and their experience from previous Ebola outbreaks. So and MSF started crying out that we simply can't handle this, you need to send more. And the problem, as I said, was a lack of willingness from foreign medical teams to deploy. There was the discussion of security of staff, that there was no way of actually evacuating people who had been affected. The capacity and of the staff being deployed, or the teams, it was very low. People didn't know about how to deal with Ebola, and also actually there was no system in place for mobilization of international teams. That has previously just been on a voluntary basis. Okay. There. So we saw these curves, and this is from the beginning of March, and here you see Guinea, Liberia, in Sierra Leone. And what is interesting to note, of course, first of all, that it's not over, but if you look on the teams being deployed by over time, you can see that the maximum capacity of isolation beds, and there were 30 of these foreign medical teams deployed to Sierra Leone, 57 in total to the 3 affected countries. But the problem was that they should normally overlap this, but the delay here was a problem, and that the maximum number of foreign medical teams were not reached until the epidemic had peaked. So that was a problem of delay in the response. So what are the challenges for responding to this type of epidemic? Obviously that you need to ensure that your response is adapted to the context of the socioeconomic situation, but also towards the needs. The problem with this epidemic is that it's a moving target. It changes, and we saw that in the previous presentation that it continuously changes. It's very difficult to plan, especially when you want to deploy teams that may take 1 to 2 months to deploy. So you take a decision today, and then it will take 1 or 2 months until you're actually on ground. And you need to have a very flexible strategy while still keeping a targeted focus. And that has really been shown to be a key challenge. Over-focused on these Ebola treatment units, and not having the flexibility to adapt. And I think now people need to get out of these Ebola treatment units and go to the communities and do much more work in the communities rather to stay in this isolation unit. There's obviously an issue with trust of the population. When we arrive with our astronaut gear and we start talking with the population, it's not something that gains confidence. You have to get rid of this gear and to speak in a respectful way with the population in order to gain their confidence. A challenge has been also the coordination with Ministry of Health, but also with other foreign medical teams. And I would say that WHO has increased its capacity to do this coordination, and that has become better. There are issues with standards, standards of care, what level should be provided, and also obviously with exit strategies. So what's as a sum up slide here? So what is the current focus of or the current status of this epidemic? Well, it's sure that it's not over yet. Even though in Liberia there hasn't been any more cases in the last few weeks. There was 80 cases in Sierra Leone within the last weeks here. So it's not over, and we saw it's even increasing in Guinea. What needs to be done with these deployed foreign medical teams is somehow to retask them, whether they will be leaving, and I understand now that the Norwegian hospital is a bit on standby in terms of activities. But how can we retask this? Well, there needs to be retasked to fit the strategy that is currently being used by the Ministry of Health and WHO, and that's what is called getting to zero. And that means that you need to focus much more on contact tracing, meaning you have to leave your isolation units and be out there and do work with the communities for them to understand that. The other important pillar, obviously, is the safe reactivation of the health system, which means that you need to open facilities that has been closed. You need to have ways to do rapid diagnostics to exclude Ebola for patients being admitted to hospitals. And you need to gain the trust of the population, which obviously is very challenging. And that gaining the trust of the population and reactivating the health service will more go, Håkon will come into detail of actually what is the current status of the other health services that are providing other types of medical care, because it's been a very much of a focus on Ebola, but it's time that we also focus on other diseases that actually has impact on public health. Thank you.
Okay, we've got time for a few questions. Yeah. Hang on, the microphone's coming.
Emiliano from UNICEF Mozambique. Congratulations for the presentation. I'm just wondering if there is an analysis in terms of data in this really tragedy and disaster, apart from how many people have died by Ebola, but during all these months where all the health units have been closed, how many other people, children, women, and adults, are also died because of malaria, any other diseases that were not able to be treated because of the Ebola disaster that affected also the staff. And I think that is important in terms to analyze the real dimension of the tragedy. And then on the second question, on your experience...
First, that might be answered by the next
Well,
presentation.
Okay.
It won't be
thanks.
answered, but it will be discussed.
Okay, thanks, sorry. And the second question was on the social mobilization and communication side. That is my area of work. I would like to know, in your experience when you were there, what really worked better and less, probably, on that side, because I know that UNICEF actually has that role of coordination in that area. At least that what should happen, and I would like to know a little bit your experience or your view on that.
Thank you very much for that, and Håkon has some interesting data to show on the first question. But on the other question, I think it's sometimes difficult to move back like 7 or 8 months and remember what the situation was like at that time. The fear, the rumors, and whatever cracks you had in the societies, they would open up during this type. People don't trust each other, etc. And I think that was one of them, I would say, problems, but also it was underestimated the value of working in doing social mobilization. There were a lot of, when I was in Sierra Leone, there was a lot of initiatives called social mobilization or community sensitization, meaning that a group of youngsters will go out with megaphones and say, Ebola is horrible, Ebola kills, wash your hands, and then they will go back to the capital. But the real issue of working with identifying the formal, the informal leaders, the religious leaders, sit down with them, women's group, etc., and really talk, inform, and win their confidence. I would say that was not done in a systematic way, at least in the beginning. And I think it was probably partly due to the fear of not only the population, but also of those trying to do this.
Hello. Thank you for the nice talk. And I'm from Norwegian Institute for Bioeconomy Research. We are just newly merged with other 2 institutions. And my question is, I think I would be more interested in what we have learned the lessons how to prevent such a epidemic problem. The cost for this after this outbreak is enormous, the whole world effort. But this is not only the case. This is, in the 70s outbreak now again. And I work a little bit with dengue fever, and that is Global Work finance the project. I learned a little bit that dengue is the same on the same line. Sooner or later there will be outbreak. How the prevention should be really enforced, or what we learned from this Ebola outbreak. Why it happened without we notice anything, and nothing was in place after it being already peaked and quite late. Thank you.
My quick answer to that, I think it relates to 2 issues. One is the underfunding health systems, low-income settings, and the context. And Ebola only occurs in this type of setting. The problem in underperforming health systems is that Ebola, they can even serve as a magnifier for Ebola. So if you have hospitals that are dysfunctional, where staff is not paid, etc., they even can magnify the epidemic and make it worse. So there are situations where Ebola would die out if there was no health care available. So that's one issue. The other one is, how can we improve this? Obviously, we have to work with health system strengthening, but also with surveillance. I think surveillance not only for Ebola, but for, as you said, for Lassa fever, for other types of diseases. So that, I think, needs to be the focus, and that surveillance could be one tool to improve the health systems and having this preparedness.
Okay, we've run out of time. We've got 2 last very quick questions and very quick answers.
Yes, my name is Anne Hatløy. Thank you for the presentation. Can you give a small reflection around the international response to the Ebola? What do we see in very many other crises is that kind of after earthquake in Haiti, after the tsunami, you will have kind of all the international organization coming in at the same time. Here you mentioned several times that MSF was the only one that was in place. How on other kind of where kind of also the aid workers are at risk in a much higher extent than on other crises? How can we deal with this in another similar situation?
So I think what you say that increasingly the more and more of these foreign medical teams have been sent to disasters. In the Haiti earthquake 2010, there were 390 registered foreign medical teams. In Philippines 2013, there were over 150. So I think this idea of a quick fix of complicated problems is an issue, especially when you have this type of problems that are related to failing health systems, and you need to have a more longer-term perspective. It could be that the surge function is okay for certain type of disasters in functional middle-income countries, such as Philippines, that you can come in and leave. Like MSF, were not working in the Philippines before this typhoon. They came in and they left. So I think you really need to sort of plan what is the type of needs, because it varies according to type of disaster, but also the context in terms of what is the likelihood of that we will be needed here in the future. And I think in this West Africa, we have an opportunity here to whether we could build some health systems for the future with these teams being on ground now.
And very quick.
Erling Svensson, Haukeland University Hospital. You were mentioning that the situation in these three countries are a little bit different. It's flattened out in Sierra Leone and decreased in Liberia. Maybe it's even free, and in Guinea it's slightly going upwards. Any speculation, ideas, and why we see those differences?
I think there's a lot of discussions on the reason for that. Some has claimed that in Liberia that the epidemic went so quickly up really triggered a change in behavior among the population. While as in Guinea, for example, you have something they call reticence, which is some sort of lack of trust or resistance to listening to governments and to officials. So that has also made it difficult to inform the population. There have even been reports of an attack of people who've gone to work and to inform those in the communities about. So I think we need to understand more of that, but there are obviously an aspect of culture, but also in terms of onset of the epidemic.
Great. Thank you very much indeed.